Welcome back to the deep dive. Today we're taking on a really big topic. We're trying to synthesize some of the densest but most crucial material for anyone facing high-stakes professional exams. We're talking, of course, about the MSRA SJT. We've integrated GMC guidelines, a load of SJT textbook analysis, and core professional notes, and it's all focused on one massive theme.
It really is. The intertwined duties of competence, self-care, and work-life balance.
Exactly.
And this is, it's probably the highest yield topic you could revise.
Why do you say that?
Because it sits right at the intersection of your personal health and patient safety.
Yeah.
So if you're studying for the SJT, you absolutely have to grasp this one core truth. Managing your own health, managing your capacity, knowing your limits. These aren't, personal luxuries.
They're professional duties.
They're fundamental professional duties. When your capacity is compromised, patient safety is immediately compromised. And that direct link is exactly why the exam focuses on it so relentlessly.
Right. So our mission today isn't just to tell you what the rules are. That would be too simple. Our goal is synthesis. We're going to try and provide a clear, exam-focused, and hopefully very memorable framework. One that explains the why.
The why is everything. Why certain actions score highest in a stressful scenario, and why that, that natural human temptation to just push through.
Which we all feel.
We all feel it.
Oh.
But it's actually the biggest professional failing the GMC wants to see you avoid. We're going to give you the professional reasoning behind the optimal choice every single time.
Okay, let's just jump right in. Inject some immediate high-stakes tension into this. Picture yourself in this scenario. It's 3 in the morning, you're on a medical night shift.
We've all been there.
You feel completely depleted, you're irritable, and you've just caught yourself making a second near-miss prescribing slip in the last hour. You know you're not on your game.
You're running on fumes.
Purely on adrenaline and anxiety. And then, of course, your bleep goes off. It's a high new WS2 patient, a score of 5, who needs an urgent review. This could require immediate life support decisions. Your judgment is clearly affected by fatigue. What is the very first thing you must do in that moment to protect the patient and, at the same time, protect your own registration?
That scenario, it hits very close to home for anyone who's done that shift. And the temptation, the cultural pressure, it's immense.
And on with it.
Just drink another coffee, push through the door, and manage the patient. But that action is, in itself, a professional failing. The first action is always internal assessment and then external escalation of risk.
So no dealing with the patient first.
No. You must stop the chain of error before it reaches the patient. And you can only do that by engaging your safety net. So if you take only one thing away from this deep dive, let it be this core truth. Professionalism in the NHS requires you to proactively notice personal risk, escalate early, secure safe cover, and access structured support before patient care is compromised.
Proactive, transparent, and documented.
It's all of those things. It's a duty.
That really reframes the whole thing. We're not talking about just taking a sick day here.
No.
We're talking about executing a mandatory risk management protocol. And the GMC, they're not vague on this, are they? The Good Medical Practice 2024 makes this duty explicit.
It absolutely does. GMP explicitly requires you to recognize and work within your limits, to seek advice and supervision when you need it, and crucially, to act immediately if patient safety is at risk because of your own health or capacity.
So this isn't just like some ethical guidance.
No, it's a non-negotiable professional mandate. Failure to act is a failure of professional probity, and it is judged severely after an incident has already happened.
And this tension, right, this conflict between the sort of culture of stoicism, get on with it, and the duty of safety, that feels like the engine that powers so many SJT questions.
It is. The scenarios frequently set up this exact conflict. They test whether you'll uphold the cultural expectation to, suffer in silence, or uphold the GMC expectation to prioritize documented, transparent safety action.
And this is where we have to pause and really think about the consequences. Why does the GMC care so much about this?
Because fatigue drives error. It's that simple. And error is the single biggest threat to patients and, frankly, to a doctor's career. And when we talk about pressures like burnout, we have to use the correct professional context. This is so important for the exam.
Okay.
The World Health Organization, in its ICD-11, defines burnout not as a medical diagnosis, but as an occupational phenomenon.
An occupational phenomenon, what does that mean?
It means it results from chronic workplace stress that has not been successfully managed. And this categorization, it reinforces a critical point for the SJT. Managing burnout is a system issue. The system, your seniors, your rota coordinator, the confidential support services, they must facilitate your safe management and rest.
So the responsibility to spot the risk lies with me.
Yes, but a responsibility to manage the system risk lies with the organization once you have escalated it.
So if I'm feeling drained, I'm not being weak by escalating. I'm actually acting as the first line of defense in the hospital's safety management system.
Exactly that. You are performing your duty to identify an operational risk. The highest scoring choice, without a single exception, always favors that honest, documented safety action.
Okay, that's a brilliant framework. Let's unpack the 4 major areas where this duty of sort of self-management shows up. We're going to try and translate the dense GMC guidance into practical, actionable SJT strategy across competence, burnout, emotional incidents, and work-life balance.
Right, let's start with the bedrock of it all, working within your competence,
Yeah,
recognizing your own limitations.
the absolute foundation.
It is. What the GMC expects is actually very simple. You must recognize your professional limits, and you must only practice with suitable supervision, seeking help when a task is unfamiliar, high risk, or just beyond your current scope. It's not a sign of weakness.
No.
It's the definitive mark of a safe professional doctor who is committed to preventing avoidable harm.
Okay, let's make this super practical. The SJT loves these scenarios, doesn't it? Where a junior doctor is asked to do a procedure they're not comfortable with, often with a ticking clock. Say you're asked to insert a central line for the first time, and the patient's condition is, rapidly deteriorating. What does the safest doctor actually do in that moment?
The safest doctor pauses.
Pauses, even if it's time critical.
Even if it's time critical. Safety overrides speed. You must not proceed beyond your proven competence. The action sequence is this. First, you stabilize the patient with measures that are within your competence.
Like what?
For example, maximizing IV fluids, giving oxygen, running the sepsis protocol, the things you know you can do safely. Second, you immediately call a senior, a registrar, or a consultant. And you state clearly, I've stabilized the patient, but I'm not competent to perform the definitive procedure unsupervised. I need immediate senior input.
That distinction, stabilize first, then escalate. Why is that so important for the scoring?
Because it helps you avoid 2 very low-scoring trap outcomes. The worst trap is attempting the procedure alone to save face.
Which could be catastrophic.
Catastrophic harm. The second trap is refusing to see the patient because you can't do the procedure. That's patient abandonment. The high-scoring action is always to provide safe interim measures and ensure constant patient care while you wait for supervision.
So you prevent the adverse event that could be caused by either overconfidence or, incompetent action.
Exactly.
And for the doctor's own protection, long-term, I'm guessing transparency and documentation are absolutely key here.
They are non-negotiable. If you stabilize and call a senior, you also communicate clearly with the patient or their family if it's appropriate. You might say something like, we're taking immediate steps to stabilize, and my senior colleague will be reviewing this within the next 30 minutes to ensure we proceed with maximum safety.
And then you write it down.
Meticulously. You document who you escalated to name and grade, when you escalated, the reason for your limits, and the agreed plan that ensures the patient is stable until the senior arrives. This demonstrates professional probity and accountability. It protects you.
So seeking help is actually the highest demonstration of competence.
That's a perfect way to put it.
Okay, let's move on to burnout. We've established it's this occupational phenomenon rooted in chronic, unmanaged stress. It shows up as exhaustion, cynicism, reduced efficacy. If I, as the doctor, start noticing these signs, what's the professional requirement beyond just feeling awful?
The professional requirement, which is linked to GMC standards and also references things like the HSE management standards, is it's twofold. First, you must act if your health could impact patient care, even if it hasn't yet.
The possibility is enough.
The possibility is enough. Second, you must seek advice, supervision, and use the support systems your organization has. The safest doctor proactively spots the signs. And we have a little memory hook for this, the 3Ds.
The 3Ds, okay.
Drain that profound energy depletion, physical exhaustion, distance, increased mental distance from your job, cynicism, negativity, and drop in professional efficacy making careless errors, missing details.
So let's focus on the mid-shift safety action. If I recognize that drain is leading to those near-miss errors, like in our 3 a.m. scenario, what is the immediate non-negotiable response?
If you are impaired and a second prescribing slip is definitive evidence of impairment, You must pause the high-risk duty. The immediate professional response is to escalate the workload risk to your senior or the nurse in charge, the NIC.
And this isn't a casual chat.
No, this is a clinical safety concern.
Yeah.
You might say, my fatigue is affecting my ability to safely manage time-critical prescribing. I need to redistribute these urgent bleeps immediately. That action stops the immediate chain of errors. It protects the patient right now.
But there's a huge psychological barrier there, isn't there? If I tell my senior I'm struggling with fatigue, there's a real fear they'll just see me as unreliable or weak.
That fear is very real, and the SJT actually tests your ability to overcome it professionally.
So how does the GMC guidance protect me? And how do I separate the clinical safety escalation from, the personal disclosure?
Right. The guidance protects you by confirming that this is your duty. Failure to escalate is the professional transgression, not the other way around. And to address the personal fear, the sources all emphasize separation. You escalate the clinical risk, the unsafe workload, to the workplace senior. But for the personal support and management of the underlying stress, you use confidential external pathways.
Okay, and which confidential pathways do we absolutely need to commit to memory for the exam?
These are non-negotiable, high-yield knowledge. The key services are NHS Practitioner Health.
Right.
It's a free, confidential self-referral service for doctors and dentists in England. It's completely separate from your NHS employer and occupational health.
And the other one?
The other is BMA Counseling and Peer Support, which is a 24/7 service. Using these structured, confidential supports demonstrates professional engagement with your health. It fulfills your duty without forcing you to disclose sensitive medical details in the immediate workplace, which should only be concerned with the clinical risk you've just identified.
Let's talk about the emotional side. Clinical work can be traumatic. We're exposed to distress, especially after severe incidents like, a traumatic death or a major error. What does a safe professional response look like here, both for yourself and for your colleagues?
The professional standard here is rooted in the duty of candor and respectful teamworking. It's about promoting a just culture,
A just culture.
meaning safety, learning, and mutual support. The GMC expects you to follow candor duties while also proactively supporting any colleagues involved. The best practice, and what scores highest in the exam, is structured support. This means acknowledging and validating the difficult emotions for yourself or for others, and arranging formal, non-punitive forums.
Can you clarify the difference between just, having a chat with a colleague versus these structured forums you're mentioning, like Schwartz rounds?
A very important distinction. Standard peer support is vital, of course, but a Schwartz round is a formalized, multidisciplinary forum. It's usually facilitated, and staff come together to reflect on the emotional and social aspects of care.
Not the clinical detail.
Exactly, not the technical details of what went wrong. It's about emotional processing and maintaining that human connection in a really demanding job. A debrief, or hot debrief on the other hand, often happens right after a high-stakes event. And while it does allow for immediate emotional release, its primary focus is often on gathering factual information and making sure the immediate next steps are covered. It sort of bridges the gap until a more formal review.
And why does focusing on this just culture, which I know is aligned with the new Patient Safety Incident Response Framework, or PSIRF, why does that improve patient care in the long run?
This is absolutely crucial for governance. In a just culture, staff are treated fairly and they feel safe to report errors and near misses. PSIRF requires investigations to move away from blaming an individual and instead look at system learning.
So things like workload, staffing, training.
Exactly. Equipment failures. If you just blame the individual, they won't report the next error and the systemic root cause will persist. By fostering a learning environment, you reduce the risk of the same things happening over and over again.
And if an incident leads to prolonged distress in a colleague or in yourself, what specific health red flags should we be looking for?
You must monitor for PTSD red flags. This is particularly important if symptoms persist beyond about 4 weeks post-incident.
What kind of symptoms?
Things like persistent nightmares, flashbacks, hyperarousal, or actively avoiding similar clinical situations. If these flags emerge, the doctor needs specialist intervention. That means formally signposting them to their GP, to practitioner health, or providing specific information based on NICE NG116 guidance on managing PTSD.
And the trap answers here?
The trap answers always involve minimizing the colleague's distress, telling them to toughen up, or violating their privacy by gossiping about their error. Both of those breach GMP duties about supportive teamwork.
Okay, finally, let's tackle balance. The sources are so clear on this. proactive planning of rest and maintaining boundaries is a clinical safety mechanism. It is not just a lifestyle choice.
That's absolutely correct. The GMC expects you to work within your agreed capacity and to ensure safe staffing when you request any flexibility. The safest doctor plans proactively. This means booking your annual leave well in advance. And crucially, it means using formal, transparent pathways for requesting changes to your working hours.
Right, so using the day one right to request flexible working.
Yes, you submit it early, and the request must ensure that equivalent skills-matched cover is secured and, importantly, documented. This moves the responsibility from some haphazard personal arrangement to a formal, governed process.
And what about the pressures mid-shift, like chronic missed breaks? It's a common reality. How do we escalate that safely in an SJT world?
Breaks are not a luxury. They are mandatory rest periods intended to mitigate fatigue-driven errors. So, if your break is repeatedly missed, you must escalate this to the senior or the site team immediately, but you must frame it as a safety issue for the entire unit.
Not a personal grievance.
No.
Yeah.
You are reporting a systemic failure to meet safe working standards. This documentation puts the responsibility for that safety risk onto the organization where it belongs. You should document the time you lost and the impact it had on your workload.
And where do people typically fall down in the exam when it comes to managing their rota or their time?
They fall for the temptation of secrecy, convenience, and heroics.
So those secret swaps on WhatsApp.
Exactly. You must avoid secret swaps on WhatsApp or text messages because these create hidden governance risks. If the colleague you swapped with then calls in sick, the hospital's official rota is wrong. Their staffing expectation is wrong.
And you get unsafe skill mix gaps.
Precisely.
Yeah.
Similarly, presenteeism while unwell, or working 14 days straight to earn time back, these are incredibly high-risk actions. The exam punishes anything that destabilizes the documented, skills-matched rota or promotes dangerous levels of fatigue.
So the rule is always arrange and document official skills-matched cover.
And notify the rota coordinator through the official channels. Every time.
Okay, we've established these 4 pillars. Now let's pull it all together into a single stepwise framework. Whether the risk is competence, fatigue, stress, the response should be unified. So we need a 4-step guide for responding to any personal capacity or competence risk.
Right, and this framework is designed to prioritize the patient first, and then the doctor's long-term protection. So number 1, stop and assess safety. This is the immediate action.
The very first thing.
The very first non-negotiable step. If you feel impaired, fatigue, stress, you're making errors, or if the task is beyond your competence, you must pause that high-risk duty. Immediately tell the nurse in charge or the senior physician that you are unsafe to continue, or that the task is beyond your limits and you need supervision right now.
Okay, step 2.
Step 2, hand over safely. This is about clinical protection. You have to redistribute the time-critical or high-risk tasks. So prescribing, unstable patient reviews, procedures, they need to go to a competent, accepting colleague.
And you have to confirm they're competent and they've accepted it.
Yes. Unsafe abandonment or delegating to someone unsuitable like a medical student is a major trap answer. It breaches your duty of handover.
Makes sense. Step 3.
Step 3, engage formal support. This is for your personal protection. While the clinical safety is being addressed, you must access confidential services for yourself. This means self-referring to practitioner health, calling the BMA counseling line, or involving your educational supervisor or occupational health for a formal assessment.
It's that separation again.
Exactly. You separate the clinical safety action from the personal health issue.
And the final step.
4, adjust work and document. This is all about accountability. You agree on temporary, time-bound adjustments, maybe altered bleep coverage, a short supervised break, or reallocating tasks so you're only doing non-urgent jobs. But crucially, you must document the plan.
What's in the plan?
The adjustment itself, the owner of the tasks, the colleague who took over the escalation threshold, when to call the senior back, and the review time when the plan will be reassessed. Documentation demonstrates accountability.
So back to that 3 a.m. scenario. The first action is to pause, bleep the registrar, and say, I've had 2 near misses due to fatigue. I need you to cover my urgent bleeps for the next hour while I take a mandated rest break, and I'm going to contact practitioner health.
Precisely. That sequence hits all the highest scoring points. Immediate safety action, transparent escalation, appropriate delegation, and engaging formal support pathways.
Okay, to help everyone internalize these complex duties, especially under exam pressure, we need some concise memory aids. things that cut through the noise. I think we have three crucial ones that link directly to everything we've just discussed.
Yes. So first, for burnout recognition and action, we use the mnemonic early. This really stresses that professional action has to start before things spiral.
Okay, EARLY. What does it stand for?
Escalate risk to your senior or the NIC. Adjust workload, hand over tasks, reach out for help, practitioner health, BMA, look after self, take a mandated rest or break, and your plan documented.
Early. I like it. Next up, for seeking help for stress or mental health, focusing on that duty of disclosure and boundaries, we use HELP.
Yes, HELP is all about that transition process. So, hand over safely, you must transition care properly. Engage support, practitioner health, BMA, the formal pathways, limited disclosure, only disclose what's needed to managers or OH, keep medical details confidential. And plan adjustments review, make sure temporary measures are in place and have a review date.
Great. And finally, for recognizing your limitations and escalation, the competence piece, we use ASK.
ASK is simple, memorable, and really powerful. Assess the risk of proceeding beyond your limits. Seek supervision, call the registrar or consultant, and keep notes. Document the risk, the escalation, the plan, and of course keep the patient safe throughout.
Perfect. Now let's try to create a strong, audio-friendly visual cue, something that reinforces the breadth of support a doctor is expected to use. We've mentioned three very different types of support: clinical, occupational, and personal. We can tie them together.
I like this idea. Imagine you're holding a safety shield.
Okay, a safety shield.
This shield isn't just passive armor. It's an active tool for communication. And it has three clearly labeled contact numbers programmed in. The first is the senior NSE. That's for immediate clinical safety and workload. The second is NHS practitioner health for confidential mental health support. And the third is the BMA counseling peer support for 247 personal access.
So the visual reinforces that in a crisis, the safe doctor doesn't just call one person.
No, they deploy all three lines of defense: clinical, occupational, and personal, often simultaneously.
And what's a simple analogy to reinforce why this is a duty?
Professional self-care is not a luxury. It's fundamental preventative maintenance, essential for critical function. It's like checking the tires, the fluids, and the fuel in an ambulance before a critical transfer. Neglecting your health isn't heroic. It's a failure of equipment inspection that risks the entire mission.
All right, let's translate all this theory into the common patterns the SJT uses to trap candidates. I think understanding the underlying tension here is crucial for maximizing your score.
We could definitely categorize the scenarios into 4 highly recurring themes. And for each one, we need to know what the exam is really testing.
Okay, pattern 1, mid-shift impairment or error. So the 3 a.m. fatigue, rising anxiety, multiple near misses, what's being tested?
It's testing your ability to prioritize immediate patient safety over professional stoicism. It's the early mnemonic in action.
So the best action is?
Tell the NIC or your senior immediately. Hand over critical tasks like prescribing or urgent bleeps. Arrange a brief, mandated pause, and immediately contact practitioner health or the BMA.
And why do the tempting actions lose marks? Things like pushing through or hiding symptoms.
They increase error risk and breach your GMP limits. They score poorly because you're choosing concealment over safety. The risk is immediate, so the response has to be immediate and documented. Taking a private 5-minute coffee break doesn't address the systemic risk.
Okay, pattern 2. Unfamiliar procedure or limit. You're asked to insert a device or do a complex consent you've never done before.
Here, they're testing your escalation competence and your honesty. This is the ASK framework. It's about balancing safety with patient advocacy.
So best action.
You stabilize the patient first. Then you explain your limits clearly. You call the registrar for direct supervision. You can then assist the senior, which is a great learning opportunity, and you document your limits and the escalation.
And the traps. Attempting it alone to save face.
That's the highest safety risk, catastrophic. But also, refusing to see the patient is wrong because that's abandonment. You have to stay involved and support the safe management of the patient under supervision.
Pattern 3, chronic rota stress and breaks. So, repeatedly missed breaks, needing flexible working, excessive workload.
This tests proactive, documented, and fair planning.
Best action here.
Escalate missed breaks immediately to the site team as a systemic safety risk, referencing HSE standards. And for leave, request flexible working early using the formal, documented NHS pathways, proposing named, skills-matched cover.
And the low-scoring options.
Swap it on WhatsApp without telling the rota coordinator. It creates those hidden governance risks and destabilizes the whole team. Secretly working extra unpaid hours is also bad. It just leads to burnout.
And the last one, a traumatic incident. A pediatric death, a major surgical complication, a big error involving a colleague.
This is testing your structured support response and whether you adhere to just culture principles.
So the best action is to validate emotion.
Yes, validate the difficult emotions. Arrange structured group support, like a debrief or a Schwartz round. Screen for those PTSD red flags. And signpost to formal help GP, practitioner health, NICE guidance.
And the tempting but wrong actions.
Ignoring symptoms for a month misses the crucial window for early intervention. And making the colleague apologize alone without support risks re-traumatization, and it violates your duty of supportive team working.
That clarity on the mid-shift impairment scenario feels so important. It really sounds like the SJT judges the doctor who tries to minimize the situation by taking a quick break alone very differently from the doctor who maximizes safety by involving the system immediately.
That is precisely the distinction. Minimizing the risk implies you don't fully appreciate the gravity of an impaired doctor working. Maximizing safety means you accept that the system needs to be aware of the risk, and it needs to manage the workload until you are fit again.
It's about accountability.
It's all about accountability.
Now, let's dedicate some serious detail to the options that look tempting, maybe feel ethically challenging, but are professionally unsound and will score you low marks. We need to dissect why they fail the professional reasoning test.
These trap answers are clever. They're designed to exploit human nature, our desire for convenience, the fear of confrontation, or the instinct for self-preservation above patient safety. They fail because they violate one of those primary duties we've discussed: safety, transparency, accountability, and just culture.
Okay, trap answer number 1. Leave mid-shift without telling anyone, or walk away without a plan.
This is almost always the lowest scoring action possible. It's fundamentally unsafe. It breaches your duty of handover, and it constitutes patient abandonment.
Which is professional misconduct.
Serious professional misconduct.
Right.
You are prioritizing your immediate relief over the safety and continuity of care for every patient under you. The GMC duty requires you to secure competent cover and document that transfer before you step away, even in an emergency.
Trap 2. Hide symptoms and work faster, or keep quiet and push through the shift.
This scores very poorly because it actively increases the risk of error. It directly breaches the GMP duty to recognize and work within your limits. The exam punishes the belief that stoicism outweighs clinical risk.
You're concealing the impairment.
And by concealing it, you're accepting personal accountability for any adverse events that happen as a result. It's a total failure of transparency.
Okay, number 3, the one we've touched on. Swap on WhatsApp without telling the rota coordinator, or a silent swap.
This is a governance failing, pure and simple. It lacks transparency, it destabilizes the official rota, and it creates unmanaged risk. If the doctor covering for you is less experienced, or if they too become unwell, the management system has no idea who is actually responsible for the patients.
It creates chaos.
Administrative chaos. It violates the duty of accountability and fair team working. All changes must go through the official rota mechanism and be skills matched.
Trap 4. Ask a student or a non-clinical colleague to cover your bleep or procedure.
This is the very definition of incompetent delegation. You cannot delegate tasks that require a level of skill or a registration that they do not possess. It breaches the limits of the delegating doctor and the person you're delegating to.
So you're just introducing a new risk.
A new, unmanaged risk into the system. You're placing your own incompetence due to fatigue or lack of skill with someone else's.
Track number 5. Blame individuals or send a public criticism email following an incident.
These actions violate the essential principles of a just culture and the GMP expectations for supportive, respectful team working. Post-incident, the priority has to shift immediately to systems learning, which is what PSIRF is all about.
And blame stops that.
Punitive actions or public criticism block staff from being honest. It prevents crucial organizational learning from happening, and that just ensures the systemic risk will persist.
Okay, what about this one? Tell only a friend, not a supervisor, about your chronic stress.
While peer support is vital, and we all need it, a friend has no official capacity to take the required safety action.
They can't change your rota.
They can't adjust your workload, provide formal oversight, or implement an accountability plan to ensure patients are safe. This fails the duty of escalation and documentation. You need a formal channel, a senior, a supervisor, or practitioner health.
And finally, trap 7. Work 14 days straight to earn time off, or refuse all others' requests for cover.
This looks like dedication, but it's judged as high-risk, unprofessional heroism. It violates mandated rest periods, dramatically increases the risk of catastrophic fatigue and error, and it really harms team equity. The SJT rewards balanced, fair, and documented work practices that recognize the need for sustainable rest.
That clarity is immense. It forces you to realize that professionalism means engaging with the bureaucratic and organizational structures correctly. It's about transparency and protocol, even when it feels inconvenient or scary.
Exactly. When you're in doubt in the exam, just ask yourself, does this action increase transparency or does it promote secrecy? Does it involve formal documentation or is it a secret agreement?
And the high-scoring options are always.
Always transparent and always documented. Okay, let's run through some ultra-short scenarios now, just to embed that instant, instinctual recognition of the correct professional action. If you realize mid-shift you're unsafe to prescribe due to anxiety,
Tell the NIC or senior immediately and officially hand over prescribing tasks to a named colleague.
perfect. If a colleague has severe nightmares and hyperarousal 4 weeks after a pediatric death,
Provide nice NG-116 information and strongly signpost them to practitioner health or their GP for specialist support.
exactly. If your scheduled lunch break is repeatedly missed this week,
Escalate this to the site team or senior immediately and document it as a systemic safety risk, not as a personal complaint.
yes. If you need complex, flexible working, leave next year for a personal commitment.
Submit a formal request early via the official pathway, proposing named, skills-matched cover and documentation of the agreement.
Last one. If you are asked to take consent for a complex procedure you have only read about,
Stop. Stabilize the patient, explain my limits, call the registrar for supervision, and document the escalation. Use the ASK framework. This has been such a detailed exploration, covering this professional duty from personal stress management right through to organizational governance. Let's distill it down now to the 3 highest yield lessons for success in the MSRA SJT.
okay, number 1, patient safety first. Always choose documented, transparent safety actions. Escalate risk, hand over tasks, adjust duties. Choose that over professional stoicism or concealment. The safe choice is the highest professional expression.
Number 2.
Use formal pathways. Seek help proactively via confidential services like practitioner health or the BMA for your personal support. And use official NHS flexible working routes for any rota changes. Avoid secret arrangements or incompetent delegation at all costs.
And finally,
Document everything. Record your escalation, any adjustments, cover arrangements, and review times. This demonstrates accountability and probity. If it wasn't documented, then professionally it didn't happen safely. And just remember, looking after yourself is not selfish. It is the fundamental professional duty that allows you to look after your patients safely and sustainably. Keep practicing these transparent, documented steps. And of course, you can find more structured preparation on professional duties and ethical frameworks at passthemsra.com.
fantastic insight, particularly for clarifying why transparency and formal escalation are really the highest expressions of professionalism in these stressful, safety-critical situations. And for you, the listener, take these frameworks early, HELP, ASK, and use them to review every future scenario or practice question you encounter, trying to embed that core logic of safety first, formal pathways, and documentation. That's how you shift your thinking from a sort of cultural perspective to a professional, governance-focused mindset. And that is how you ace these professional dilemmas. Thanks for bringing your sources to the deep dive. We'll catch you next time.